So, Amha, your case number 2, please.
Thank you, Arlene. So
And
the
this time,
second
Beppe to
case I
lead.
have is a male patient, 47 years of age, who was diagnosed with chronic phase CML in January 2021. His Euroscore long-term score was intermediate. And he did not have comorbidities. After hydroxyurea cytoreduction therapy, he was started on imatinib 400 milligrams, and he achieved hematologic response in 3 months and maintained this until May 2022. On subsequent follow-up, his platelets started to drop to less than 50,000, and imatinib was actually held for some time. In October 2022, he was lost to follow-up for 8 weeks, and he came back with a white cell count of, I have to refer to my note because I cannot see on the field. So it was 18,600. 18,600. His hemoglobin was reasonable. In October 2022, he was lost follow-up for 8 weeks and came back with a white cell count of 18,600. Hemoglobin was 12.1, platelets 92,000, and imatinib was decreased to 300 milligrams, increased to 300 milligrams twice daily because of the increase of the white cell count. After 2 months, his white cell count continued to increase despite high-dose imatinib. In January 2023, repeat bone marrow examination showed still chronic phase CML with less than 5% blasts. By the way, we do gene expert if we have reagents. So the BCR-ABL was 55% at this time. Kinase domain mutation analysis could not be done. We don't have facilities. The patient claims to take his medications regularly, and he was, based on clinical grounds, he was switched to nilotinib, 400 milligram twice daily. He continued to have intermittent thrombocytopenia. And because of this, because of the increased discontinuation of treatment, nilotinib was decreased to 200 milligrams twice daily. So the more recent white cell count is 13,200, and the platelet count is 78,000. So the question is, what is the practical approach in the management of this patient with drug-related toxicities such as thrombocytopenia? Thank you.
Naeem, would you care to comment?
Yeah. So, Amha, this is a case that we deal with some of these cases once in a while. Although some of these cases who they say that have a larger stem cell pool which are diseased usually develop these thrombocytopenias and or neutropenias in the initial phase for the 6 to 9 months, and then gradually they continue to improve their counts and become better, even sometimes on the same TKI or change of the TKI. So now over here you have already used 2 of them. One is imatinib, and the patient couldn't tolerate enough therapeutic doses. And now also with nilotinib, the patient is having intermittent thrombocytopenia. And your concern is that it's 200 milligram BID and the platelet counts are still 78,000. Now there are 2 ways to go. You can either continue on 200 milligram BID and wait for another 3 months. This may improve. If not, then you may have to change to a third TKI. And in this case, as Beppe had initially given his comment on a different case also, that sometimes bosutinib is somehow better tolerated from the perspective of the response of hematological toxicity. Because dasatinib would also be very, certainly toxic to the hematological response as well as ponatinib. So I would switch to bosutinib in case if there is no further improvement. If you continue on 200 milligram BID, sometimes patients do take a bit longer, especially if they're responding by cytogenetic or molecular. If the molecular continues to go down, you can continue 200 milligram BID, especially that the patient is only in chronic phase. If you think that the patient is still not responding and is
Yes.
unable to tolerate, then go to bosutinib.
Amha, what do you think?
Yes, thank you. The worry is, as you can see, it's the bone marrow showed actually less than 5% blasts, but the BCR-ABL is 55%. So,
Yeah,
I mean,
this was in January 2023, but then
yes,
the patient is
yes.
on nilotinib since that time right now. So what was the last
Yeah.
BCR-ABL?
We did not do the BCR-ABL because of, logistic problems. But the thing is, his white cell count is borderline, and his platelet count is maintained above 50,000. So we are continuing of nilotinib 200 milligram twice daily.
Beppe, did you have a comment? I think we can hear you now well.
No, I think that certainly I would say that to continue TKI is imperative in this case because we have 56% of BCR reversal. So I think that absolutely we have to do it. In some of these cases, I would try also to use L-Thrombopag if you have access to L-Thrombopag, also starting for 25 milligram per day, and then maybe increasing a little bit high in order not to stop the therapy, the TKI therapy, because of, and maybe also achieving the full dosage of the TKI that you are using in order to continue the therapy, because otherwise this is, I would say, a problem. Thrombocytopenia may be a problem, but of course, by the use of stimulating the TPO. So I think that this is also possible, in addition to what Naeem said before.
Naeem?
Did you have access to L-Thrombopag?
No, not yet. Sorry.
This is a problem. So you can follow clearly what has been suggested by Naeem. I think that this is a good option just for this case. And this, you must be also, would say, really be sure that the patient is taking the drug, because sometimes, if I remember well now from the slides that I cannot see, this is a rather young patient. Am I correct or not?
Yeah, 47 years old.
Yes.
So if it is young, I would say generally young patients, they tend to be less compliant with the therapy. And in this, there were some period of discontinuation, if I'm not wrong, of the therapy of this patient. So you must also to convince him just to follow the therapy, because this is important for his life, I would say, not only for the treatment of CML. However, at the moment, the risk of progression is rather limited. So I think that it would be a good balance just to use a TKI at the dosage that it can allow. And in the future, there will be the possibility to have access to romiflozin. Probably this could be a good option too. You can also ask Novartis for compassionate use of romiflozin, although this is out of registration, but compassionate use is always possible.
And perhaps something that we can pick up and move on with, and many recurrent themes that come up again and again.